mechanisms behind them. So I think it's really interesting, and I hope you enjoy it. You've probably heard of a lot of these conditions: ALS, muscular dystrophy, Huntington's disease, Alzheimer's, Parkinson's. I might be missing some, but we're going to go through those and kind of the genetics behind them. There are a lot of unique genetic mechanisms in neurological diseases, so I'll go through all of that, and I hope you enjoy. Yeah, so let's get started. I'm going to start by going over something that I somehow don't think I've ever gone over when it comes to like DNA and making proteins, but it's something that kind of comes in with some neurological conditions. So we're going to start with a basic concept, and that is of introns and splicing. So if you haven't seen my previous videos, maybe go watch the ones, the general ones where I talk about like DNA replication and transcription. But you might remember that we have our DNA molecule. So this is our DNA. It's kind of like a recipe book. So a particular gene is like a recipe to make something. In this case, a protein. So it provides all of the instructions, the ingredients to make a particular protein. But what I haven't talked about is the fact that a gene, like the instructions for making something, has both exons and introns. Exons and introns. So exons generally are the parts of the gene that specifically code for an amino acid or a part of a protein. And then the introns, some of them have like information that doesn't really matter. Some parts of them are important for like telling the body where and how to express these genes. Some of it is like instructions for the DNA replication and the transcription, but it's not directly a part of a gene. So I don't know, I guess it kind of makes sense to think of the exons as the ingredients, the flour, the sugar. The introns are kind of like the instructions. Like, this is how we're gonna do it, this is where we're gonna do it. So then transcription happens, which is where the DNA molecule is turned into RNA, which is like an intermediate messenger that goes on to make the protein. And when that happens, we do transcribe our introns and our exons. So that is all part of the pre-mRNA molecule. But then the DNA or the RNA goes through splicing, which is where the introns are spliced out and the exons are joined together to make the final mRNA. And so then during translation, we make the protein with just the exons. Now, sometimes certain introns are left in, sometimes certain exons are spliced out. It's all kind of how we get a lot of variation. So we have like 20,000 genes in our body, which isn't that much when you consider how many processes are going on in our body and how many proteins are being made. And so one way that happens is that one gene can lead to various different transcripts and thus proteins because of how the introns are spliced or not spliced out. So I hope that makes sense. Introns are not necessarily like coding regions of the DNA, but they are still very important for directing splicing and directing how transcription happens. Yes, so that's splicing and introns. Now we're going to get into all of our neurological conditions and the genetics behind causes muscle weakness and atrophy, which is like the wasting away of the muscle tissue. So it mainly causes weakness, problems with speech and swallowing, purely muscular, so it doesn't generally affect like cognition and the way you think, but just the muscles. So we will talk about the genetics of this. So the gene involved in spinal muscular atrophy is called SMN1. SMN1. And this gene makes the SMN protein, which is very important for your muscles. And this gene is made up of 8 exons. It might be more, I don't know, but these are our exons, and then it's transcribed. We have all of our exons, and it makes the SMN protein. We also have a gene called SMN2, which is a nearly identical gene. Same exons, very identical. However, about 90% of the time, the exon 7 of this gene is spliced out. So you can see here that we're missing exon 7 in 90% of the transcripts that come from this gene. It's due to like a single change of a letter in this gene that causes the splicing out of exon 7. And when that happens, we get an SMN protein that is unstable. It gets degraded easily. It's not functional. But about 10% of the time, that exon 7 is not spliced out, and we get our normal SMN protein. So why is this important? SMA, or spinal muscular atrophy, is caused by mutations in this gene. The most common mutation is for exon 7 to be deleted. So it's deleted in the child, and that essentially leads to this. It leads to all of our SMN protein looks like this and gets degraded, and so that's where we get the muscular atrophy from, is that we're not getting normal SMN protein if we have that mutation. The homozygous just means that this is a recessive condition, which means you have to inherit an SMN mutation from both of your parents. So if you have one copy that's perfectly fine like this, you won't have the condition, but you need 2 mutations, one coming from each parent to actually get the condition. But so this comes in when we're talking about the types and the severity of SMA, because even if this is deleted, exon 7 of our SMN1 gene, we still have SMN2, and SMN2 is still making 10% functional protein. So we're all getting a little bit of SMN, but we can inherit different numbers of copies of SMN2. And so there are 5 types of SMA. Type 0 is the most severe. So for all of these types, we have a mutation in SMN1, so we're not making protein here. In type 0, people only have 1 copy of SMN2, which means all the SMN protein that they're getting is coming from this 10% of that 1 copy. And so it's a very, very severe disease. Type 0 is very rare, and I believe, like, most of the time people don't live past infancy with type 0. Type 1 is, I believe, the most common, and it's associated with 2 copies of SMN2, which means we're getting a little bit more of this protein, so we're functioning this is also important because it is the basis of a lot of gene therapies for SMA. I think SMA is cool because it's honestly like the biggest success story in gene therapy is with SMA, because there's a gene therapy that essentially targets the SMN2 gene and makes it not splice out exon 7. So these people have perfectly functional SMN2, it's just SMN1 that's not working. So the gene therapy makes it where this is happening way more often, and so they are making way more functional SMN protein, and it's essentially curative. Like, it's so cool that this gene therapy is literally curative for SMA, and there's babies born with a condition that would be in a wheelchair by the time they're 2 years old, potentially not living past adolescence, and they're like cured of this genetic condition, which I think is so awesome. But that is SMA. Next, we're going to talk about another one that has to do with splicing and exons, and that is muscular dystrophy. There are a lot of other types of muscular dystrophy, but we're specifically talking about Duchenne and Becker muscular dystrophy, which are, I believe, the most common, but yeah. Okay, so with these two conditions, we are looking at the dystrophin gene, which is another gene that's very important for our muscles, and it's a big one. It's I believe the largest gene in our body, or the one with the most exons. So I've drawn 5 here for the purposes of this video, but there's like a lot of exons. I don't know if it's like 70 something in the gene, but I've just drawn 5. So, okay. So in normal dystrophin, let's say we have these 5 exons, and then the black lines are our introns. Okay, so if you look at this, these all fit together. So number 2 fits into number 1, 3 and 2 are both flat, 4 fits into 3, and then 4 fits into 5. So everything is continuous. It all fits perfectly in the reading frame, and that gives us our normal dystrophin protein. Now, if you watched my last video where I talked about frame shift mutations, this comes from the fact that we essentially read the gene, the recipe, by groups of 3 letters. So 3 letters at a time. Now, if you delete 3 letters, exactly 3 letters, then the first word is normal, the third word is normal, the fourth word is normal, everything's normal from there on out. You're just missing that second word, let's say. However, if you delete 1 or 2 letters, or a multiple of 1 or 2 letters, and then shift everything over, now every single word after that deletion is changed. It's all different because we're shifting everything over. So that's a frame shift mutation, and they're generally very severe because they alter the entire protein and generally lead to no protein being made at all. So that's what I'm showing here, is that if we delete exon 2 only, just delete exon 2, well, now exon 3 does not fit into exon 1. Exon 3 doesn't fit into exon 1, and so we get a frame shift mutation, and everything else will be shifted over and essentially messed up. And so we get no real dystrophin protein, and that's what gives us Duchenne muscular dystrophy, which is the most severe type. This muscular dystrophy leads to, again, like muscle weakness. It can also lead to heart problems, all sorts of muscular issues. And Duchenne, without treatment, it generally leads to death in like early adolescence. So it's very severe. However, down here, let's say we delete both exons 2 and 3. 2 and 3, so this is a larger deletion. However, now exon 4 fits perfectly into exon 1. They have the same shape. And so even though we deleted 2 exons, we've restored the reading frame. So these are still going to code normally because we're in the same reading frame. We didn't shift everything over. And so we're gonna get, it's gonna be an abnormal dystrophin protein, but we're still going to make some dystrophin protein. And so that's what gives us Becker muscular dystrophy, which is a less severe form of muscular dystrophy. And normally people can live, you can have a normal lifespan potentially, or slightly shortened. So yeah, and this again is kind of the topic of gene therapies. So there are a lot of gene therapies that essentially, let's say someone has this type of mutation, so they're missing exon 2. The gene therapy would essentially force the gene to also cut out exon 3. So if we're also cutting out exon 3, now we're getting this. So the gene therapies essentially convert a Duchenne muscular dystrophy phenotype to a Becker. So these people born with Duchenne are now having the less severe phenotype of Becker muscular dystrophy, and they're living much longer lives with less symptoms. So that's those conditions. As far as the inheritance, this condition is X-linked recessive, which means it is, this dystrophin gene is located on the X chromosome, which, if you remember, that is the sex chromosome. So biological males, most biological males are born with an X and a Y chromosome. Females are born with 2 X chromosomes. Now with SMA, we talked about recessive inheritance, where you have to inherit 2 mutations, one from each parent or one on each chromosome to have the condition. So that is essentially what we're seeing. However, males who have an X and a Y chromosome, they only have that one X chromosome. So if they inherit one mutation in dystrophin on that chromosome, they are going to have the disease because they don't have anything else protecting them. They don't have a normal copy of dystrophin. Whereas if a female inherits a dystrophin mutation, she has her other X chromosome to compensate. So she has the normal dystrophin on that chromosome. And that is why this condition affects boys way more than it affects girls, because it's on the X chromosome. So we can see here that this is a pedigree. The colored in shapes are people that are affected, in this case with muscular dystrophy. Squares are boys and circles are girls. So we can see grandma and grandpa not affected. They have 4 kids. Both boys are affected, both girls not affected. Okay? Then the daughter has a son who's affected. So what we see here is that grandma is a carrier of a dystrophin mutation. She can't have a daughter with muscular dystrophy because even if she passes on her mutation, the dad is giving the daughter a normal X chromosome because he doesn't have muscular dystrophy. However, there's a 50% chance with each of her we see that she must have given her daughter her dystrophin mutation, which makes her daughter a carrier and then gives her a 50% chance of having a son with muscular dystrophy as well. So that's what we see, is that the boys are more likely affected and the females are not, because they are carriers. Now, females with muscular dystrophy, or females with a dystrophin mutation that are carriers, can still have some symptoms. So we wouldn't say that they're completely unaffected, but they can have mild symptoms like heart problems, some muscle weakness, but not to the level of boys that have a dystrophin mutation. And this is just a pedigree showing what I described, which is dad has an X and a Y, no dystrophin mutation. Mom has a normal X and an X with a dystrophin mutation. And so for their girls, 50% will have no mutation. Maybe that's what happened with her. 50% will also be carriers. That's what happened with her. For the boys, 50% will not be carriers at all. 50% will have muscular dystrophy, like these boys. So yeah, I hope that makes sense. That's X-linked recessive inheritance, and I think that's all I wanted to say about muscular dystrophy. Those are conditions that I actually haven't seen in my neurology rotation because they're mainly like pediatric conditions, like people are diagnosed from birth. So I didn't get to see any of them because I'm doing adult neurogenetics. But now we are going to get into our adult conditions. Okay. We're also going to be talking about a type of mutation or mode of inheritance that I have not talked about yet. So we are going to talk about Huntington's disease. This is unfortunately a very terrible disease. Huntington's disease causes abnormal movements, so it can cause something called chorea, which is like kind of dance-like movements of the body. It can cause tremors, and then it causes like psychiatric symptoms, depression, anxiety, hallucinations, cognitive symptoms, memory loss, mood changes, all sorts of things, and it unfortunately is fatal. People sometimes live like 10, 15 years after diagnosis, sometimes shorter, sometimes longer, but it's a very terrible condition. But we are going to talk about the genetics of it. So the specific gene we're talking about is called HTT, and so this is, we'll call this our gene. This is just to show that there's all these instructions, all these parts of the gene on either side of the part that we're talking about. So this isn't the whole gene, it goes farther in either direction. But what we are talking about is this section of the gene that has repeated segments of CAG. So our nucleotides, the letters that make up our genes, our recipes, are C, A, T, and G. And there are certain parts of genes that will have repeated segments of a certain number of nucleotides. So like CAG, CAG, CAG in this HTT gene. So normal, no Huntington's, is when you have 35 or fewer repeats. So I know I only drew 3 here, but having 35 or fewer CAGs is normal. That's normal, no Huntington's disease. Here, what we have is called a repeat expansion. So you can see that we have days instead of 3. Obviously, 5 is less than 35, but for illustrative effect, this is an expansion of those repeats, and that is our Huntington's disease mutation. So if we have 36 to 39 repeats, that's kind of intermediate, where some people will develop Huntington's disease symptoms later in life, some people won't. We're not really sure what to do with that range of repeats, but if you have 40 or more repeats, that's when we see Huntington's disease in pretty much everybody that has that mutation. Yeah, I think that's what I wanted to say. The other thing that is important about most repeat expansion disorders, so disorders that are caused by this expansion of repeats, is something called anticipation. So what this means is that with each generation, when someone has one of these expansions, generally the gene that they pass on to their child will have even more repeats in the child. So the repeats continue to expand with each successive generation. I believe the reason this happens is because when the DNA is being replicated and transcribed, the more repeats there are, the DNA replication and transcription essentially gets more confused. Like, it gets more lost in the gene when there are so many repeats. It's like, where am I? And the DNA will like come apart, and then more repeats end up getting added because it's so unstable. It's like not how it's supposed to be, and so you see a greater number of repeats in future generations. And so that's what we're looking at here. We will say that so neither grandparent has Huntington's disease. They both passed away with no Huntington's disease. Well, they then have one daughter who has Huntington's disease, and she develops it at age 50 years old. So let's say that she has 46 repeats. So that falls in our disease range. That's why she got Huntington's disease. Let's say grandpa or dad has 34 repeats. So that's why he did not get Huntington's. He's in this normal range. However, the closer we get to that 35, 36, the likelier the chance that it will expand in the future generation. So he didn't have a repeat length that caused Huntington's, but his daughter now does because that repeat expanded. And then we see that she has 3 kids, and this child gets Huntington's disease at age 31, and this one gets it at age 28, so much earlier than their mother. And let's say he has 59 repeats. So again, the repeats are expanding, and the more that they expand, the earlier the symptoms will show, and generally the more severe. And so that's what's called anticipation, is when we see the severity increasing and the age of diagnosis decreasing in successive generations. And we can also maybe assume that this daughter got like the same 34 repeats from dad, so maybe it didn't expand in her, but then it did expand for her son, and he maybe now has something like 40 repeats, so he got Huntington's disease. So yeah, and when you get over like 60 repeats or even more, that can be juvenile Huntington's, so Huntington symptoms that develop even in childhood, which is really unfortunate. recessive. This is dominant, so everybody has 2 copies of our HTT gene. And let's say that here, or maybe here, Dad had normal HTTs. So let's say he has 25 and 27 repeats. That's normal. Mom has 1 normal copy that she got from Grandma. 1 normal copy, let's say 22 repeats. And then she has the abnormal copy, which was 46 repeats. So then 50% of her children will have the normal number of repeats, 20 something. So that's like this child. But 50% will inherit that repeat expansion. And here we can see that it expanded even more in the child. So for anyone with Huntington's, 50% chance that their children will inherit that repeat expansion as well and get Huntington's. Definitely, Huntington's disease is like a really heavy thing in genetic testing. It's really like the only genetic condition I can think of where you're not affected from birth. Like, you're not born with it, you're not born with symptoms, but we can do genetic testing and tell you that for certain you are going to get Huntington's disease. There are not really any other genetic conditions like that that I can think of. Like, either you are born with symptoms, you have it your entire life, or we can say, okay, you have this gene mutation that gives you a risk factor, like you have a 20% chance of developing Alzheimer's, but this is one where it's like we can do genetic testing in a completely unaffected individual, no symptoms, and tell them 100% you are going to die of Huntington's, which is just a big thing in genetics, big ethical issue of like, should we test people for this? Because that is horrible, horrible news to get, that at some point you are going to develop this disease. So it's definitely just, yeah, a very serious, big topic. I have not seen someone yet in my rotation who has a family member with Huntington's but has not been tested themselves. I did see a patient on my first day who we suspect may have Huntington's due to her symptoms, but I haven't seen a predictive testing one like that, which I think would be really interesting and also very heavy. Yeah, that's Huntington's. Okay, next condition. I think we have 3 more conditions that we are going to talk about. The next one is ALS. ALS, amyotrophic lateral sclerosis, also known as Lou Gehrig's disease. So Lou Gehrig had it, as did Stephen Hawking. So that's why it's a little bit more common in like the media. ALS, another terrible, terrible disease, steals away people's movement, muscular function. It steals away ability to speak and swallow, and eventually that is fatal, generally within like 2 to 5 years of diagnosis, which again, absolutely awful. In contrast to Huntington's, ALS, most of the time actually, we cannot find a genetic cause. So there's not one gene that's the ALS gene and it's running in families. It's kind of, we don't really know. So sometimes we don't know, sometimes it is due to a mutation, and when it is due to a mutation, there are a lot of different genes that can cause it, which makes it a lot more complicated and a lot more difficult to counsel on. But let's talk about some of those genetic factors. So of the time that we see ALS, it is sporadic, meaning that nobody else in the family has it. This person has no family history. 10% of the time, it is familial, meaning multiple people in the family have ALS. When it is sporadic, so this is the only person with ALS, 15% of the time we can identify a genetic cause for the ALS. When it's familial, so multiple people have it, about 70% of the time we can identify a genetic cause, which even this feels pretty low, and it's most likely just a result of not enough research yet. If it's familial, if we have multiple people with ALS in the family, it's likely that there is a genetic cause. It's just maybe in that 30%, we just haven't identified what that is yet. We haven't identified the gene that's responsible. But the most common gene mutation associated with ALS is in a gene called C9orf72. Nice, simple, easy name. We call it C9 for short, so that's a little bit easier. And C9 mutations make up about 40% of familial cases. So of that 10%, 40% have C9. Over here, if it's sporadic, I think it's kind of like 5 to 7% are C9. Don't quote me on that. But just like Huntington's with the C9 gene, the type of mutation is a repeat expansion. So as opposed to the CAG, this time we have G, 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 C, C. So it's these 6 nucleotides that are repeated over and over again. And if you have more than 30 repeats, that is a mutation that can lead to ALS. Now, the interesting thing about C9 is that it is associated with ALS. It is also associated with a type of dementia called frontotemporal dementia. Frontotemporal dementia is not really like Alzheimer's. It's not really a memory condition. It is more, so there are 2 variants of FTD, or frontotemporal dementia. One leads to severe behavioral concerns. We had a patient with FTD who wired thousands of dollars to a scammer because they fully believed that the scammer was legit. Things like that, very out of the normal behavior for this person, acting very strange. There's also a language variant, so FTD, where you aren't speaking normally, your words aren't making sense, or you can't process language. So language or behavioral. But people with a C9 mutation, they're at risk of both ALS and FTD. So sometimes we see one, sometimes we see the other, sometimes we see both. And the inheritance of C9 mutations, same as HTT with Huntington's disease, it's autosomal dominant. So we can see if someone has a mutation, there's a 50% chance of passing it on to their kids. So this female has ALS, and we will say that she has a C9 mutation. She has 4 kids, 2 of them perfectly fine. One of them has frontotemporal dementia. So he inherited C9 from her, and he got FTD. And then he had a daughter who also inherited it, and she has ALS. Over here, her daughter has ALS, and she has a son that has both ALS and FTD. So this is just to show that it can cause one, the other, or both, which is very unfortunate. The very first patient that I did by myself in neurology was a C9 case, where the patient's brother has a C9 mutation and ALS, and we were testing the patient for the C9 mutation that his brother has. Okay. I do see a lot of ALS because where I'm doing my rotation has an ALS clinic, so like a specific clinic day that is for ALS patients. So I've done a lot of that. Okay, next condition is another common one you've probably heard of, and that is Parkinson's disease. Parkinson's disease is mostly a disorder that causes tremor and movement differences. So tremors, shaking, sometimes problems with walking, and sometimes it can cause problems with like memory and mood, but that's kind of less characteristic, and it's something that we'll talk about a little bit. One thing about Parkinson's is that most of the time we cannot find a genetic cause. Parkinson's is thought to be very multifactorial, which essentially means that it's a combination of environmental factors, genetic factors, aging, random chance, but about 15% of the time we can find a genetic cause. One thing that's interesting, so Huntington's disease, when you have a mutation, you will get Huntington's disease. ALS, if you have a C9 mutation, there's a nearly 99% chance of ALS or FTD. With Parkinson's, for people with these gene mutations, even if we do find a genetic cause, still it only increases the risk of Parkinson's to like maybe 15, 20, 30%. It's not saying, yes, you will absolutely get Parkinson's because you have this mutation. So it's definitely a case where like we don't do a whole lot of familial testing or predictive testing in people that don't have Parkinson's yet, just because if we were to find that you have a mutation and we're telling you like, okay, you have a 25% chance of getting Parkinson's and there's nothing you can do about that, like that's not very helpful. It's not, I don't know, like we don't want people to freak out because they have a chance of Parkinson's. So that's kind of something unique when it comes to this type of genetic testing. But so Parkinson's can be split into early onset, so onset before 50 years of age, or late onset after 50 years of age. And there are different genes that are associated with both types. This doesn't mean sometimes these genes can cause earlier onset, sometimes these can be later onset, but this is just in general. Early onset, there are 3 genes, these 3 that have autosomal recessive inheritance. So people inherit 2 copies of this mutation, one from either parent, and that leads to early onset Parkinson's. It is much more likely to get Parkinson's if you have one of these mutations. These are kind of the ones I was talking about where it's just like an increased predisposition. So for late onset, these are 2 genes that and still it's only in about 3 to 7% of Parkinson's cases. So really not that common to see, but it is the most common. People with GBA mutations are more likely to have some of those other like mood and memory and cognitive symptoms as opposed to people with sporadic Parkinson's or Parkinson's due to other mutations. So that's one thing to note about GBA. The other main thing with GBA, you may have heard that people with Parkinson's will often get something called deep brain stimulation. It's basically where they implant like electrodes in your brain, and it can help with Parkinson's disease symptoms. However, it's been found that for people with a GBA mutation that get deep brain stimulation, it can sometimes lead to worsening like cognitive symptoms, so cognitive decline. So that really is the main reason that we do genetic testing for Parkinson's, is because we are seeing people that are in consideration for deep brain stimulation, and if they have a GBA mutation, doesn't necessarily like disqualify them from deep brain stimulation, but it's definitely something to think about, like to consider when thinking about if someone should go through with deep brain stimulation. So yeah. One other thing about GBA is that this follows autosomal dominant inheritance, meaning to have that risk of Parkinson's, you need to inherit one GBA mutation and then you'd have one normal copy. There is a separate condition called Gaucher disease that happens when you have two GBA mutations. So theoretically, if like two people had GBA mutations, then they are carriers of Gaucher disease. So that's just something to keep in mind. It's not something I've ever like talked about with a patient, but I guess could be something for like reproductive knowledge, that if you know you carry a GBA mutation, maybe get your partner tested to see if they also do, because your kids could have a chance of getting Gaucher disease. But yeah, that's just like a random thing that came to mind. It's not even to do with like neurology, but yeah. Okay, the last condition we're going to talk about is, I think, the most common one that we've talked about so far, and that is Alzheimer's disease. Yay. You probably are most familiar with Alzheimer's disease, I would assume. It is a type of dementia that mainly leads to memory problems. Yeah, it's very common. It's like the 6th or 7th leading cause of death, at least in the United States. I also had a grandma with Alzheimer's, so this is really interesting to me. Alzheimer's is another one that is very multifactorial. Not often do we find a genetic cause of it. It's a lot of environmental factors that cause it. So again, not really doing a whole lot of predictive testing because we don't want people to put a ton of weight on it if, it's not actually meaning that much. But there are a few genetic factors that can be at play. So mainly when it comes to early onset Alzheimer's, which is about 5 to 10% of Alzheimer's cases, so not that much. I believe the definition of early onset is younger than 65 years old, but typically if we're seeing these mutations, we're gonna see Alzheimer's at 40, 45 years old, very, very early, as opposed to 64. We're not as concerned about that. one thing I will say about the actual like biology of Alzheimer's is that one of the main biological features of Alzheimer's is the accumulation of something called amyloid plaques in the brain. So there's a protein called amyloid beta, and when amyloid beta clumps together, it forms these plaques in the brain of amyloid beta protein, otherwise known as amyloid plaques, and that leads to like the atrophy and degeneration of the brain, which leads to Alzheimer's symptoms. And so these genes are involved in that amyloid beta production and function, and that's why they can lead to Alzheimer's disease. Specifically, APP stands for amyloid precursor protein. So this gene creates the protein that is essentially the precursor for amyloid beta. And so if you have certain mutations in APP, it can lead to an increased production of abnormal amyloid beta that's more likely to form those plaques and cause Alzheimer's disease. So that's where like the biology of this comes in. Something interesting about APP is that it is located on the 21st chromosome. If you know, Down syndrome is trisomy 21, so having 3 copies of the 21st chromosome. Well, that also means that people with Down syndrome have 3 copies of APP, which if you have 3 copies of APP, the amyloid precursor protein, there's a higher likelihood of creating more amyloid beta, more abnormal amyloid beta, and more amyloid plaques. And so people with Down syndrome are actually very, very, very likely to get Alzheimer's disease at a young age, by their 40s or 50s, which is something that not a lot of people know, that it's very common to see Alzheimer's disease with Down syndrome. Late onset, anything after 65, typically we don't find a genetic cause. It's a lot of environmental factors, multifactorial, but there is one risk factor gene called APOE. This gene is actually involved in like cholesterol metabolism, but it is partially associated with Alzheimer's. You may have heard of it because I think it's included on a lot of like 23andMe tests. Like you can do commercial testing for APOE, which wouldn't recommend. But so there are 3 different variants or alleles of APOE. If you have the E3 allele, that's normal. That's like baseline. The E2 allele is thought to be protective against Alzheimer's, so actually having a lower risk of Alzheimer's. And then the E4 allele is a risk allele, so it puts you at an increased risk of developing Alzheimer's. And because we have 2 copies of every gene in our body, you can get E2, 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 E3, E4, E3, E4, E4, like any combination. And so obviously E4, E4 would be the highest risk of developing Alzheimer's. The main reason we don't do predictive testing for this is that even with E4, E4, the worst allele of APOE, there's a 30 to 50% risk of Alzheimer's. It's important to note that Alzheimer's is very common, and if you just have a first-degree relative with Alzheimer's, a parent, you have like a 25% risk of developing Alzheimer's as well, just by having a first-degree relative. And so that's like about the the same risk as if you have this E4 allele, which is basically the reason why, like, they don't really recommend doing testing for it, because they don't want people to be like, oh, I'm doomed, I'm definitely getting Alzheimer's, when your risk is like the same as someone who has a dad with Alzheimer's, if that makes sense. So yeah, this is a gene that we know of to be associated, but not really something we do a ton of testing for. So yeah, long story short is neurology is really complicated. Neurology has so many factors involved, so many environmental factors, so it's very, very interesting, but it's also very confusing, and yeah, these symptoms can be caused by so many things, and you have to take so much into account when you're thinking about like neurological genetic testing. So yeah, I hope that's what you gathered. I didn't even talk about cerebellar ataxias, which is the most common thing by far that I've seen in my neurology rotation, but I just thought it would be too complicated, and they're not like super well known, well described syndromes, so I didn't want to, I don't know, I wanted to go through the things that you've probably heard of, or maybe you have like a family member with, because that's, you know, more like relevant, I guess, I don't know, to a lot of people. But yeah, I hope you enjoyed that. I feel like I talked super fast, so I'm sorry that I talked so fast, but I hope you enjoyed this genetics video. I really like making these. I think they're so fun to make. So yeah, I have like so many papers from all of the videos that I've made, but I hope you enjoyed that. It always means the world to me when people like enjoy watching these and comment that they love the video and everything. So yeah, thank you to those people for watching and supporting me and loving my videos. Yeah, thank you guys for watching. Wish me luck on my next rotation. Maybe I'll do one of these for every rotation. My next one's like a laboratory industry rotation, so if it looks like there's information to do a video, I'll do it. If not, I won't, but yeah. Thank you guys for watching, and I will see you next time. So sleep well, everybody.